Good afternoon, everyone. Welcome, and thank you for joining us today. My name is Bob Gabbay. I'm the Chief Scientific and Medical Officer for the American Diabetes Association, and it is my pleasure to have you join us for this important conversation. We are going to be focused on the risks of we're going to be focused on amputations, but we'll explain why in a moment. Um, I will really want to thank you in particular for taking the time out of your busy day and joining us for a conversation that I think you'll find both worthwhile and informative, and really think about what we can do to reduce the health disparities that exist in this country around diabetes. How we can work together to address that. Um, I will tell you that I mentioned that we're going to talk about amputation, and so let me frame this a little bit. Why are we here? Why is this such a big issue? Well, first of all, every 4 minutes, someone in America is having an amputation due to diabetes. And more than 60% of the non-traumatic amputations in the US are in people with diabetes. You all can appreciate what a devastating challenge this is for someone and their family when they have an amputation. And amputation rates are not the same across all people. So there are significant health disparities when it comes to amputations. In particular, people of color are twice as likely to have an amputation than whites. Twice. Unacceptable. And if you take a look at this first slide, I want to highlight that these disparities vary by geography. So it is not uniform. And if we can get that slide up, not sure if that's showing. And if we're having technical challenges, which in the way of the world happens now and then, I will just give you a sense of what you would have seen on this. So if you look at the amputation rate across the U.S., it is not at all uniform. There are parts of the country where it's relatively low, and then there are other parts of the country where it's significantly higher, as much as 3 to 4-fold higher, particularly in the Southeast. And a lot of this has to do with access to good care, and something that we're going to be talking about today a great deal. Let me just highlight this a little bit. We know that access is not uniform. We know that poverty impacts this, that there are significant health disparities. And that's why a central focus of the American Diabetes Association's effort to reduce health disparities has focused on preventing amputations. And that's part of our Health Equity Now initiative. I encourage you to go to the American Diabetes Association website. You'll learn more about that initiative, the Bill of Rights, one of which is people should have the care to prevent amputation. That should be something that doesn't happen in this day and age. And what we'll hear today is from two expert colleagues, really about how we can largely prevent a lot of these amputations and what we need to do to make that happen. I'll before I get into the meat of what are the causes and what can we do, I'll just share a quick story from a story myself. When I was in medical school a number of years ago, literally my first surgery that I scrubbed in on as a medical student was a lower extremity amputation. And I was just reflecting on this. So the medical student's job in the operating room is to do the low level stuff. And so my job was to literally to hold the leg while they were, in essence, sawing it off. And it was a gruesome event. And there was a moment that I'll never forget. I'm holding this leg. You know, the individual obviously was anesthetized. And all of a sudden, like the leg was separated. Like I'm holding this thing, and then it's like, oh, this person no longer has a leg. And now knowing what I know, how that's preventable. And then years later, this is still a huge problem. And in fact, over the last several years, amputation rates have increased 50%, despite what you'll hear today. So we really have a lot of work to do. I'm going to start with some basic questions. I have a program, Ask Dr. Bob, online, so I'm used to answering questions. I'm going to sort of level set us with some common questions. So what is PAD? We're going to talk about PAD a lot. So PAD is peripheral arterial disease, and often what it is atherosclerotic disease of the vessels of the lower extremity. So you're probably familiar with atherosclerotic disease of the heart, leading to heart attacks, or the carotid arteries leading to stroke. Well, this is atherosclerotic disease and, in essence, clogging of the arteries in the lower extremity. Another thing that people sometimes mix up is, so what is PAD versus diabetic peripheral neuropathy? And so peripheral neuropathy is the nerves that provide sensation in the case of one of the most common forms of diabetic neuropathy. They provide the sensation to the lower extremity, for example. And in people with diabetes, they lose that ability to sense their feet, and therefore are also at high risk for amputation. And Dr. Albert will talk more about that in his section. So who is at risk for PAD? PAD is a leading cause of amputation. So who's at risk for PAD? Well, diabetes is amongst the highest risks for PAD and for lower extremity amputation. So people with diabetes are 10 times more likely to develop a lower extremity amputation. What are some of the other risk factors? Well, smoking, big factor, hypertension, coronary artery disease, kidney disease, cholesterol, obesity. All of these things increase the risk of PAD and therefore of amputation. And so what are the symptoms of PAD? How might one know if they have it? And the most common is something called claudication. Claudication is pain, typically on walking, that then gets better when you rest. That's the early signs of PAD, but many times there may be no symptoms. How do we know if somebody has PAD? How do we make the diagnosis? And we'll talk more about this, but it's a simple ankle brachial index. It's measuring the blood pressure between the upper extremity and the lower extremity. If there's a big difference, that sort of says there's some clog, there's some blockage of the arteries to the lower extremity, and therefore the risk of amputation. There's a term that you'll hear us talk about a lot, and so let me define that, and that's chronic limb ischemia or chronic limb threatening ischemia. So what is that chronic limb ischemia? It is chronic, so it's been going on for a long time. Ischemia, not enough blood flow, and it becomes limb threatening at a certain point. And those are the individuals at that moment. First of all, we want to prevent that, and we'll talk about how to prevent chronic limb ischemia. But we'll also talk about the treatment. Dr. Eglin will talk about that. And first, we need to know when somebody is at that point, because their risk of amputation is extremely high if nothing is done. So how would somebody know that they have that? Well, they would have that claudication, that pain on walking that got better when they rested, but now it would advance to the point where they have pain at rest without any activity. So they're really at high risk for an amputation. Or they have an ulcer that is not healing, and that's another thing to watch out for. And again, their amputation risk is quite high. So what we're going to do next is talk about how to prevent all of these things from happening. And the good news is they're largely preventable. From the medical point of view, I'm an endocrinologist. It really boils down to the ABCs of diabetes. A1C, getting good A1C, which is a measure of blood sugar control. B for blood pressure, good blood pressure control. And C, cholesterol, good lipid control. It's the ABCs, and if people smoke, making sure that to help them quit smoking. And an important part of all of this is having the right healthcare team. And podiatric doctors become a critically important part of the team, and that's a segue into the next person that's going to join our conversation here. And what we'll do today is we'll do this presentation, cover some of this material that will sort of level set things, and then we will move into the treatment. So let me introduce this amazing first guest that we have. And so Dr. David Alper is a podiatric physician who's practiced in a solo practice 35 years in Belmont, Massachusetts. Really unbelievable. We were talking about that earlier. He specializes in the prevention and preventative diabetic foot care, which he'll talk more about in a moment. He also is active staff on Mount Auburn Hospital, which is one of the Harvard teaching hospitals. He's a member of the leadership board of the American Diabetes Association in New England and on the board of trustees of the American Podiatric Medical Association. Really a leader in this field. He serves as the chair of the Belmont Board of Health for, again, 30 years in Massachusetts, and is also in the Massachusetts Association of Health Boards. He is a sought-after speaker and writer on the issues related to preventing amputations and appropriate foot care. And when he's not in the world of feet, he shared that you can find him in a blacksmith's forge, which is interesting. So thank you so much, Dr. Alper, for joining. And maybe you could start by sharing a little bit about, we talked about how bad amputations are. So why is it important to examine the feet? What role does that play in this equation?
Well, thank you very much, Dr. Bob, and thank you for that overzealous introduction. And thank you all for joining us today. And the question leads itself to, why do you have a podiatrist sitting between, a world-renowned endocrinologist and a guru of vascular care? And the reason is that podiatry, especially when you're dealing with PAD and diabetes, are really the front liners to this. We are the ones that are going to be picking up the problems, hopefully early enough, so that you're not going to be leading down the road to surgery and amputation. This first slide that you see right here is a perfect example of this. We need to be able to have you look at your feet. And if you do nothing else, you lay people and you physicians both, if you learn nothing else by listening to us today, please learn that you got to start looking at the feet, because the feet are what's really going to tell you what's progressing, hopefully before it's gotten to the point of surgical intervention. PAD is very much a silent disease at the beginning. And the changes that you have may be things that you don't really notice every day, that you're not looking for. Because, of course, we look at our bodies every day, and the slight changes are not something that really stand out any more than you put on 3 pounds or you lose a little bit more hair. But if you start noticing some simple changes, you suddenly notice you don't have hair growing on your legs and your feet anymore. Well, the grass doesn't grow if you don't water it. And that's a sign that the hair follicles are not getting circulation. If you notice that swelling is setting in, if you notice that your feet are starting to feel colder no matter what the temperature is outside, if you're seeing discoloration, if you could bring that first slide up again. This is a very typical example of somebody that would come into a podiatrist's office with type 1 or type 2 diabetes, and they're not having the claudication. They're not having the cramping in the legs. But what they are having is feet and legs that are not quote unquote normal. And if these things are not checked, if you leave your socks on at the doctor's examination, or you never look at your feet at home, you're not going to be noticing these types of changes. And yes, we need things like ankle brachial exams and Doppler exams and things like that. But this is what should really be alerting it. And I will say to you categorically, shame on your doctors if they're not looking at your feet, and shame on you for not doing it as well. Because it's absolutely true that one of the biggest problems this country has is disparity in the preservation of healthcare. But these are things that you could be doing for yourself and then advocating for yourself at your doctor's visit. I should be going to a podiatrist, or you should be checking my feet and should be doing it regularly. And when you have your podiatry exams, these are the types of things that you'll do. What you should not be doing is trying to treat these simple things yourself. If you could put up the next slide for a moment, please. This is an unfortunate patient that came to me who had a little blister between their toes, and they decided they didn't want to call me. They didn't want to take the time or make the copay. And so they tried to treat it themselves with a razor blade. And this is the result because your circulation can't handle it. Now, why do these things happen in the feet more often than the rest of the body? It's simple mechanics. It's simple mechanics, my friends. The feet are the farthest away from the heart. The heart has to work the hardest to get the blood there. The blood vessel pathway is the longest. So getting by all those clots and occlusions that Dr. Bob spoke of is the longest there, which means it's less likely to get down there. And if you can't get the blood, you can't get the healing. And so something as simple as a cut from a blister can lead to that unfortunate patient that you had there in front of you, where by taking the moment to see something, by examining your feet, and by bringing it to the doctor because it doesn't look normal, that's what's going to prevent losing a toe or something even worse from that. Now, if you could put up the next slide for a moment, please. The foot exam is an incredibly simple one. It does not require equipment. And frankly, some of these things you can even do yourselves. And I teach, and my colleagues teach our patients. So you have two pulses in your feet. If you start in the upper left, you have what's called the dorsalis pedis on the top of your foot and the posterior tibial pulse on the inside of the ankle. Both of these should be able to be felt. You really can't take your own pulse because, of course, the question is your ankle feeling the pulse in your fingers, or is your fingers feeling the pulse in your ankle? So it is good to have somebody do that. But it's a very simple thing to check, just like you check on your wrist. You then do what we call a quick capillary filling in the third slide. You simply push on the big toe until the skin turns white. And what you're doing, of course, is you're squeezing the blood out of the tiniest of blood vessels. It, let go, should turn red again in less than 3 seconds. 3 Mississippis. If it takes longer than that, there's the problem with circulation going on here. That blood is not getting to the very far end there. Once again, something you can do yourselves. Slide 4 and 5 tests one of the things that we use for seeing whether or not you have no diabetic neuropathy, a loss of sensation. And that's the distinction between sharp and dull. By using a sharp object and then a simple dull object, you have you close your eyes and you simply mention whether you're feeling it or not and whether or not it's sharp and dull. If you go skip over the next one to the last slide, you see that they're applying a little brush to the top of the foot. And that's simply just saying, do you have a sense of soft touch? Do you feel something simple touching different surfaces of your feet? The final one, of course, is the classic physician exam of checking for reflexes. This entire exam that's on this slide takes less than 2 minutes. And I will say it again, shame on your primary doctor if they're not doing this when you appear. And shame on the podiatrist that you see if they're not doing this every time you come in. And you should have a podiatrist in your realm. I know it sounds self-serving because it certainly was a wonderful career for me. But the reality is if you have diabetes, you need an eye doctor to watch for retinopathy, and you need a podiatrist that should be watching for neuropathy and for changes because of PAD. Now, somebody comes into my office and I see these changes, and I have in my pocket the phone to Dr. Egeland and his colleagues. And they're going to be thrilled because I'm not sending them somebody with a diabetic ulceration, with a hole in their foot. I'm not sending them somebody with a darkened toe or with that toe we saw earlier. I'm sending them somebody that's saying, I'm concerned about this. And this is exactly what Dr. Bob was talking about. Early intervention, which means, I again put it on you folks. Do this on yourselves. It takes no time. Do it to your spouse, do it to your family members, and make sure your doctors are doing it. It really can't be done enough. And this is where you get the early intervention. By the time you've reached claudication, by the time you need to get out of bed in the middle of the night because the ball of your foot is burning, by the time you have a wound on your foot that's not healing, you're already deep into PAD and ischemia. You're already in a situation where we consider you at high risk. So early and often is going to be the case, and making sure that you constantly check your own feet and advocate for yourself to make sure that this occurs. When I do have to pass them on, Dr. Egeland, it's your game now.
Well, thank you, David, and thank you, Bob. And I just wanted to emphasize really the importance of physical exam. And I think we talked a little bit about the symptoms of PAD, and unfortunately, as we, despite getting best care, diabetes is a disease that does lead to sometimes more advanced forms of PAD. And the good news, though, I think if there's a multidisciplinary care team, and David talked about the importance of early detection of the disease, a multidisciplinary care team can sometimes then really have good outcomes. In fact, when I was doing my training, and this is, a couple decades ago, there was no real treatment for PAD short of a very invasive surgical procedure called surgical bypass. And unfortunately, surgical bypass, like any surgery, is a very serious intervention. And patients with diabetes, unfortunately, do not often have good healing prognoses. So in the old days, and this was only maybe 15 years ago, that was really the only treatment option. And now, as you can see on this slide, I'm happy to be part of a company that is in part bringing new therapies and innovative therapies that don't require a long incision, don't require use of an operating room, but in fact use a very minimally invasive technique called endovascular procedures. And as you can see here, this is the extent of the wound created in these procedures. It's a very simple needle, and it's similar to the procedures that are done for coronary artery disease, except instead of treating the heart, we're treating the vessels that David and Bob talked about. And there are a number of ways that those vessels can be treated. And if you go to the next slide, over the course of the last 3 decades, really tiny devices have been designed to open the arteries. And without, again, using a scalpel, the first of these, invented in the 80s, is called angioplasty. Many of you have heard of that for coronary disease, but you can use angioplasty also in the legs to open atherosclerotic disease. This is a very small balloon that essentially opens the artery and restores blood flow. And as David said, the whole goal for these procedures is really to not injure the tissue further. So hence we use a minimally invasive technique, but to restore blood flow. And to restore blood flow then allows the wounds to heal. Unfortunately, patients with diabetes, and I remember this in all surgical procedures in my surgical training, really have wounds that are difficult to heal. Patients with diabetes have about 5 times greater degree of what we call dehiscence, or wound breakdown, subsequent to surgical procedures. So for patients with diabetes, again, the endovascular or minimally invasive approach, not creating more tissue injury, is very important. So in addition to balloons, there's other very small devices. Stents can be deployed. These are small little metal tubes that are basically threaded through the artery, just as we talked about earlier, and then open up and hold the vessel open, so that again restores blood flow. And then the last device, invented a little over a decade ago, is called atherectomy. And in more advanced forms of disease, it's possible to not only make the vessel more elastic again, but to sometimes even remove the diseased tissue. And again, that restores flow. So all of these procedures in the end really ultimately allow the procedure to be done with sometimes same day. So again, with the surgical bypass surgery, the last one here that I had mentioned before, that historically would have required at least an overnight stay, if not multiple days, and a very long incision. But due to the advances in the technology, I think it's very important, just as David said, to be evaluated by a multidisciplinary care team. And I would just emphasize that patients that are maybe facing some of these more advanced forms of the disease, whether it's a wound, should not be afraid to ask about potential treatment options. And the best forms, again, involve really four things: control of the diabetes or the glucose, comprehensive wound management. So if there are advanced forms, the CLI, having a specialist that takes care of wounds in particular, the endovascular or the vascular specialist, and then often infection control. So if there's a team, unfortunately, as the disease progresses, if it does become more severe and is either CLI, CLTI, having a multidisciplinary care team can reduce amputations by 50%. And those hospital systems that have implemented the multidisciplinary care team with specialists that get together and discuss the best plan of action, 94% of those centers saw a reduction in amputations after implementing those programs. So again, this is very emblematic of the specialties we have here: medical, treatment, podiatry, wound care, and then of course, surgery or endovascular procedures. So that's just a quick snapshot, but I think, patients and their providers should understand that there's really been rapid advances in the forms and treatment of CLI, the more advanced forms, and patients can really benefit from these procedures, avoid an amputation, and go back to a very normal lifestyle subsequent to a pretty minimally invasive procedure. So again, there's hope, but it's very important to aggressively manage disease and aggressively manage the diabetes. But then again, if things do progress, and it does, there are treatment options available. So with that, I think, again, let's end on a course, I think, of hope for treatment, and we'll continue to advance the technologies in the field for these patients.
Thank you so much. And Dr. Eglin, I didn't get a chance to introduce you, and the audience should know your background, which is quite impressive. Rhodes Scholar at Oxford, PhD in biochemistry, Harvard Medical School physician. Really, like, you know what you're talking about, and your leadership at Cardiovascular Systems Incorporated has really been outstanding. And I think both of you really highlighted some really important points. While I'm going to ask people to throw in questions in the chat, and I'll sort of assign them to you to the appropriate person. So one question, and maybe this is for you, Dr. Albert. Why do patients often not have their feet screened for conditions that can lead to amputations? Like, it seems so simple.
Well, and of course, I can't speak for every physician that's out there, and hopefully we do have some physicians that are learning a little bit to step in as well, too. A visit with your physician nowadays is such a time crunch, that there are so many things that have to occur, including, unfortunately, electronic health records that just steal time away from the patients. And for that reason, you find that your physician visit nowadays more deal with acute things than chronic things. So you're more likely to get attention for that sore throat or that clogged ear than you will for your diabetes, which is there every time you simply visit them. It's why I tried to emphasize so much that people with diabetes, really all patients, need to be advocates for themselves. They need to be able to say, Dr. Smith, please check my pulses in my feet. Make sure you take your socks off in front of the doctor. Now, you should also not be concerned about seeing an NP or a PA. These are frontline medical people nowadays, and they're actually often more likely to do this for you than your primary physician, who is going to be dealing with the reason that you're in the office today. You also, again, want to make sure that if you are diagnosed with diabetes, as Dr. Eglin said, You want a panel of people taking care of you. You need that ophthalmologist. You may need that kidney specialist. You certainly need an endocrinologist. And part of that team should be a podiatrist as well, so that you are getting this tested away from your doctor's office. So part of it comes down to the unfortunate nature that doctors don't always have the time. It's a bad reason, but it's a reason. But part of it is you've got to make it front and center important to you, and it'll be important to your doctor.
Absolutely right. And, you know, the American Diabetes Association has a program that we said, knock your socks off. Go when you go in to see your primary care provider, your primary diabetes provider, take your socks and shoes off. That will cue them and remind them, like, whoa, take a look at my feet, because again, an ounce of prevention really is what this is all about. Dr. Eglin, this might be a good question for you. So someone says, what should someone do if they're referred for an amputation? They're told they need to get an amputation. What should they do?
Well, I think, you know, unfortunately, as part of our goal here, we're trying to educate not only patients, but also physicians about the advances in care. And it is the state of affairs that the technology has advanced so rapidly that not all treating physicians, whether they're surgeons or interventional cardiologists, are aware of all the treatment options. And so, you know, here at my company, we spend a lot of our time and effort to educate the medical community about the treatment options. But unfortunately, and this is particularly true outside the United States, not all physicians are aware of the treatment options. So it is very important to ask very pointed questions about the reasons for the amputation. There are situations where an amputation is medically appropriate. However, most of those are in the cases of very severe disease, life-threatening disease and infection of the bloodstream. And that's a very rare and very extreme form of PAD. So unfortunately, as I mentioned, not all physicians are aware of the treatment options. So it's very appropriate to ask, you know, for a second opinion, to ask for the reasons for the referral of an amputation, to really ask the physician who's recommending the amputation about what we talked about earlier, the desire for a multidisciplinary review of the case. And then ultimately, it's up to the patient and the patient's family to determine their level of comfort with that recommendation. So again, I think I don't want to second guess necessarily the physician. However, it is appropriate to always ask for a second opinion and make sure that that recommendation is well grounded in the science and the data. And it is, you know, amputations, as we talked about, it's a serious procedure. It's unfortunately an amputation itself has a degree of mortality associated with it. It's a relative use, as said Bob. It's a simple procedure, but it's a major procedure. And, you know, obviously the impact to the patient and their lifestyle goes without saying. It's a major change, and so shouldn't be taken lightly.
Dr. Bob, if I one other please. Second, what Dr. Eglin said, you know, we're talking about amputations of limbs, but amputations are toes too, you know, and very often, unfortunately, you lose a toe in 2021, you lose the lower leg in 22, and you lose the upper leg in 23.
Yeah.
You know, and so prevention, you know, if you're told that you need to lose a toe, that doesn't necessarily mean you need to lose the leg, but boy, somebody better be looking at the blood flow above that ankle. It's not just a matter of taking that toe off. So we need to define the parameters here. And Ryan, I couldn't agree with you more that physicians need to be educated yesterday about their options that are out there. And if you're not presented all the options, Lord, go to somebody else and hear the other options that are available.
Yeah, you know, David, I'll just add even further and emphasize that, you know, in my experience, a simple toe amputation can lead to further infection. I think the statistics are something like a third of all amputations, even toe amputations, ultimately lead to another amputation. Right. And, you know, unfortunately, because of diabetes and the challenges of wound care and wound healing, you know, it's unfortunately not the last trip in the amputation series. So very important. Good point.
Yeah. And, you know, Ryan, I was struck by what you said earlier, that if you compare centers that do the right team-based care and have the multidisciplinary team. The amputation rate is half what it is elsewhere. And so, yeah, I think very much encourage people to think about a second opinion because losing a limb is so devastating. And some of this will just get to this very last question, and then unfortunately we're out of time. The question is, do we need to educate healthcare professionals more about opportunities to prevent amputation, and how can we reach them? Well, I am glad you asked that question, and I'll take that one. Absolutely, that's part of what this program is about, and an effort by the American Diabetes Association to raise the understanding, because particularly on the new surgical procedures, many providers are not aware of this. These are relatively new, and they're really sort of breakthroughs in the options that are available. And that's why many times people are referred for amputations. Those providers don't know that there are these other treatments available. So we are actively involved, and we appreciate all of you attending. Thanks everybody for taking the time to join us. Thanks so much to our two outstanding experts to talk with us today about this really important issue. Together, we can ensure that people do not lose their limbs, that we can prevent amputations, and it's doable, and we can do it together. So thank you, everyone, for joining us, and thanks to our two speakers.
Thank you very much, Dr. Bob, and everybody out there.
Yes, appreciate the efforts.